We know that Wilson's disease affects almost all parts of the body, from liver and brain being the most important. And we'll try to see from brain point of view what happens.
Is not working. Is the mic working?
And this is one of the largest study of Wilson's disease, the phenotypic characterization. As my previous speaker pointed out, that this is more weighted towards neuro-Wilson's because our center caters to patients with neuro-Wilson's. And we had but patients with hepatic or hepatoneurological or neurological, pure psychiatric, osteomuscular and others. Coming to the three key movement disorders which comes to us: Parkinsonism, dystonia, dysarthria. The dysarthria part we'll try to address. Patients also have mental subnormality, dominant behavioral abnormality, seizures, which we are going to discuss today. So autosomal recessive familial disease. So the previous session was on genetics, but we will be talking about some issues related with counseling. Almost all patients of Wilson's disease, neuro-Wilson's, will have some degree of speech involvement, and it's a problem both from analysis and evaluation and therapy point of view. From behavior, it's very interesting. I'd like to tell like a 19-year-old man, a very bright pre-university student, was evaluated in 93 with absent-mindedness, social withdrawal, anxiety, reduced attention, concentration, declining academic performance of 1 year duration. He was diagnosed to have schizophrenia with affective dysfeatures and received flufenazine, chlorpromazine and trihexyphenidyl. Following this, he had mild improvement for a year, but again he developed severe extrapyramidal symptom and stopped medication. He was suspected to have drug-induced extrapyramidal and was prescribed symptomatic treatment. 2 years down the line, that is 93 to 95, he was again having progressive worsening of behavior, visual and auditory hallucinations, tremors, cyalloria, gait disturbances. So he visited psychiatrist at our center and he received 5 cycles of ECT and was advised clozapine. There was minimal improvement until May 96, when the patient's mother reported again worsening of tremor, difficulty in talking and walking. During the case review, he was detected to have KF ring, low ceruloplasmin and total copper, and that's how the diagnosis was made, and he improved later on. So this took us to look into the dominant psychiatric manifestations of Wilson's disease. We analyzed about 15 patients out of a group. One of the psychiatric resident he looked into, and the common was bipolar affective disorder, schizophrenia and cognitive decline. So some message related to when they come to the psychiatrist, we wanted to give some message. In the paper we highlighted family history or past history of jaundice, neuropsychiatric disorder or premature deaths, family history of any of these things, recent onset behavioral or personality change, extrapyramidal features, undue sensitivity to neuroleptics, poor therapeutic response to symptomatic treatment including ECTs, undiagnosed bleeding symptoms and recurrent pathological fractures. One should have red flag. Then we undertook another study, prospectively 50 patients we evaluated for behavioral symptoms, when we found that 12 of them had some degree of behavioral and majority had bipolar affective, few had depression and dysthymia. Dr. Prashant helped us to evaluate the seizures in Wilson's, and we found about 7% of them had Wilson's. We don't know exact why Wilson's happen, seizures happen. It may be unknown or deafferentation of white matter or copper deposition per se. Some hypothesis regarding pyridoxine deficiency is also generated. So in the neuropsychiatric aspects, cognitive and behavioral changes may be the initial and dominant symptom and frequently pose diagnostic and therapeutic challenges. Affective symptoms are common. Precise structural correlates needs exploration. While patient have clues to diagnosis, a high index of suspicion is necessary. This is one study of neuropsychological assessment which we did, and we found that frontal subcortical and frontal lobe was the main affection. And patients do have multiple disability, so rehabilitative measures and psychological supports are required, and it should include global physiotherapy, vocational rehabilitation, speech therapy. We'll try to have those questions with our expert panelist. And it's important, like any other chronic illness, to look not only into scales which should also have quality of life, and in one of our study we did look into the quality of life and they did improve with treatment. So we'll now, with this background, we'll have some questions now. We have a child has come with new onset neurobehavioral symptoms. When to suspect Wilson's disease? Dr. Prashant, can you help?
Yeah, the question comes many times since the morning. We framed these questions based upon what discussions we were having in the morning, so that we try to address many of the issues what was being raised in the group. So the question is, new child comes with a new onset behavior, means reducing scholastic performance, not writing properly, some subnormality. All these things are. So when should we raise the question of Wilson disease? It's difficult that every patient who comes with subnormal behavior or subnormal IQ should be assessed for Wilson disease. But any child who was apparently well all the way and off late is developing suddenly some type of scholastic reduction, handwriting getting deteriorated significantly, or if they develop some extrapyramidal features in the form of, let us say, difficulty in walking, not walking properly, dragging one of the foot, or slight change in speech, or is there any associated jaundice? If there was a history of jaundice prior to this, which was not for any acquired causes of jaundice, then probably you should consider that this set of children should be evaluated for Wilson disease. That was one issue what we wanted to cover up here. Now it also comes that many people just can come with a neurobehavioral issues, because we are speaking from the behavioral therapist or a child psychologist therapist point of view. When we started to look into it, the number of patients who come there and have Wilson disease is almost negligible. So it's mostly the patients will end up with the treating pediatrician or the families when they start picking up these type of symptoms, which was not noticed. At this point of time, we should start considering them to have Wilson disease, or to work up for at least for Wilson disease.
So the message is that new onset neurobehavioral symptoms, the resident should have proper history taking, look into the small things like any family history, where deaths were there, any systemic features are there, which otherwise may be missed by psychiatrists. So this emphasis we should do.
What age group are we meaning when we say child? What age? Is it above 10 or?
Let us say age group of 5 and above. That's what I'm going to tell it. Even though the mean age is around 9 to 10 years or in the early part of the second decade. However, children can present early also. So any child who was apparently doing well, then started to have a deterioration in his scholastic performances. In addition, if you notice any subtle extrapyramidal neurological features, definitely you need to go ahead and do it. But depending upon other features, you need to keep in mind what differential diagnosis. But this is Wilson disease, as I told you, it's a disease of high clinical suspicion. If you don't suspect, you'll never diagnose it. So keep it and always in your differential diagnosis, start working it up. You may get a positive or you may negative, but always keep in your list of differential diagnosis.
Just to add to that, if you are looking at the neurological presentation, two things we can also ask for. We know it's an autosomal recessive disease, so if there is any family history that is suggestive of that. And the second thing is, most patients, 98% patients with a neuropsychiatric manifestation will have a KF ring present. So that's the simplest thing that one could refer to an ophthalmologist and pick that up.
So the next question is, like, patient of Wilson disease on treatment develops behavioral symptoms. What we should do, how to approach?
So the question is whether the behavioral symptoms is caused by Wilson disease or the behavioral symptoms are caused by the treatment what you are giving to the patient. So most of the time, like penicillamine usually never causes, zinc never causes any behavioral issues. That's what we need to remember. The primary medications may not cause. However, if the children are receiving secondary medications for symptomatic therapies, like anticholinergics or some other medications if they are receiving, you need to cross-check for that, whether it is a drug-induced behavioral cause or it is due to the process of the disease because of Wilson disease. The one thing what it comes to mind is, if patient is on treatment and then they are developing new onset of symptoms, you should always look whether the drug compliance is good, whether they are taking medications properly or not, whether in spite of drug complex, whether the copper hemostasis is appropriate or not. You may be giving medication, but probably the copper hemostasis may not be appropriate enough. So you need to start looking from the biochemical perspective also, whether the treatment what you are giving is working out. So then based upon that, you need to make a call on that, what type of decoppering therapies you need to change, or if required, behavioral therapies to involve definitely a psychiatrist to decide on what type of therapies are required.
One thing I would like to, if patient had seizures, and nowadays all of us use levetiracetam, and it says to be the drug of choice for Wilson's disease also, because it has no drug interaction. So one of the important side effects of levetiracetam is behavioral. So that we see in epilepsy patients, but here also that point we should keep in mind. Now, we all know that patients with has dysarthria, and our experience says that complete returning to normal probably never happens. So here comes the role of speech evaluation and therapy. So I invite Mr. Shivshankar to share his views about how to evaluate and give therapy to these patients.
Thank you, Sanjeev. Now, this is a very common disorder that you see in the Wilson's disease group. It occurs in 85 to 90% of the children having the dysarthria. And when we talk about the dysarthria, it's not just the linguistic component of the speech, it's also non-linguistic component of the speech. So you have a segmental and suprasegmental. So we need to look at both things to arrive at the dysarthria. You may not see any articulation defect in some children, but you do see prosthetic deficit in them. So we need to put these two together. And the type can be, usually it's of a mixed type and varying in spastic, ataxic, and hypokinic and dystonic component. Besides speech being affected, the other oral movements like swallowing and smiling is also maybe impaired. Some of the acoustic analysis can be done to look at the vocal cord movement and see whether there is a good closure or opening, or how the voice is being produced, how is the laryngeal movement and things like that. Well, of course, these are all just in the research part of it. However, when you look at the intervention part of it, or therapy part of it, what we are looking at the reacquiring or generalization of the skills and effective social participation to the extent possible, and of course, the classroom learning. So the focus of speech intervention will be of targeting simple to complex oromotor activities and to targeting the speech subsystem. I'm happy that in the morning that we have seen people talking about speech, and Madam also showed a case who recovered speech so well. And I just met her outside and asked her. She's now grown up, and I remember that I must have seen in Nimhans way back. And I asked her, so your speech is so good. Surprisingly, she told me, I don't follow any exercises. I speak, that is it. That is speech therapy for me. Beautiful. As long as the patient is happy, I don't have to go and intervene there and say, no, you have to do this, you have to do this. Well, of course, in the beginning, probably we must have targeted the speech into 4 systems of respiratory, phonatory, resonatory, articulatory, and prosthetic subsystem, because these are the 4 subsystems which contribute to the better speech production. From this respiratory point of view, that we need to look at the respiratory support and the postural adjustments, and probably duration of increase of the breathing, like deep inhalation, exhalation exercises, prolongation of vowels during exhalation, and respiratory flexibility, use of breath support to produce various stress patterns and words. So we need to select those segments to improve upon the respiratory system. And then we'll have to focus on phonatory, resonatory, which improves the voice quality and optimizing the function of vocal cords, improving the voiced versus voiceless kind of a sound production, so that the child will be able to control the laryngeal movement. For example, if I look at pa and ba, the sounds that you take it, pa is a voiceless sound and ba is a voiced sound. Because if I ask you to produce pa without a, you can't produce. That's it. In ba without a, if I ask you to produce, So there's a sound which is being produced. So there's a vocal cord movement. There's no vocal cord movement. So it's a voiceless and voice sound. So we work on those voiceless and voiceless, shifting of those, and probably looking at the velopharyngeal competency, nasal flow versus nasal and voice modulation training. And the articulatory part of it is more of a placement technique, accuracy, direction, and range of motions, modeling of speech production, cueing techniques, perceptual judgment, speech pacing and syllabication, and pitch and loudness processing. So we have many techniques which we adopt to improve upon the one at this perceptual level, and the other one is the production level. So we need to look at because most of the children do have some kind of cognitive impairment. So we need to look at the cognitive linguistic aspects to improve upon the speech. Yeah. I'll just can I play this?
Click on the
Click on, it's not there.
Right?
No, it's there.
Prashant? I don't know. This is pre-therapy. And if you look at post-therapy,
On the picture. On the picture.
मेरा नाम नारायण हालदार, मेरा पिताजी को लक्ष्मी कांत हालदार.
so you can see a good improvement in speech. It is just the auditory and visual feedback. So if you can maintain those auditory and visual feedback, the children can improve on the speech. And there are very difficult children also where you cannot do speech therapy. In such patients, maybe we may have to look at alternative and augmentative communication. Thank you so much.
So coming to the role of child psychologist, so we'll just request Dr. Rohini to tell why somebody should refer to you.
Good afternoon, everyone. I think in the purview of a life-threatening disease like Wilson's, the role of a psychologist or a counselor, and more so of a multidisciplinary team approach, is often missed. And I think one of the reasons for this is the interactions that we have with parents, children, and later as adolescents and adults. So to just cite that as an example, when we meet parents and we ask them that what gets you here or what brings you here. A parent will always talk to you about the illness, will always talk to you about how difficult it is for the child physically to manage Wilson's, how it is difficult for them to move from one doctor to another, to undergo so many tests that they have to, so many hospitalizations that the child or the adolescent or the adult has to go through. And that's the basic account, the basic detailing that a parent would give us when we actually meet them. Now moving on to a child, when we actually meet these children, so they're probably age 5 years, 8 years, 10 years, they're obviously more articulate as they're growing older. Their accounts are very different, so they will not have complete understanding, of course, of what is Wilson's, though they know that they have something, that there is a dietary change that they need to follow, that they are having admissions, but that's not really their focal point and that's not really their focus. The focus is, of course, just like any other child, going to school and getting your grades and mingling with children, having peers of the same age. And then when we move on to adolescents and adults, what we see is a stark difference from what parents are reporting in the beginning to what a child is feeling a little later, and what an adult and adolescent is going through. And what really an adult and adolescent is going through is this, that I have missed so many years of my schooling. I've had to eventually drop out of school. I've done correspondence courses. I'm not getting a job anymore. Some of them have a lot of suicidal ideation. They're also, probably taking psychiatric help. They're also taking mood stabilizers. That's the kind of stark difference in terms of reporting from a parent to a child to an adolescent and an adult. Having said that, we do understand that, when you have something like Wilson's, it's always about the medical treatment first. But missing out on this is also very crucial, because it has a psycho-emotional and social impact on these children. For example, there is an adolescent who dropped out of school, grade 7, and did his correspondence grade 10 and grade 12. And and after that he did a few courses in computers, and he went for a job. So he went for a job and they said, okay, we'll take you. They kept him for about 2 to 3 months and they didn't pay him a penny. Okay. Imagine a person who knows that they have got Wilson's. Imagine an adolescent who's gone through so much in terms of absenteeism, dropout, not performing well, so many negative strokes socially, because our culture is such that we are always focused on our academic performance, unfortunately. And here he is getting another stroke from a person saying that anyway you're not so good, so I'm not going to pay you. You can be here and do what you wish to. And he's come to such a stage that in spite of a good family support, very, very good family support, he believes that really he cannot do much. And he says that, there's so much that I want to talk to you about. That's the kind of feeling that we are getting. Now he is, I think he's 22 years of age. He's 22 years of age. There's another case that I'd like to definitely bring to your notice, where she's done
Just
schooling.
address the psychology part of it.
Yeah, so I'm coming to that. But we also... Okay. So also there are a couple of other cases who is into suicidal ideations, and one of them has even attempted suicide. Now, for children and adolescents, I think the first thing that we need to do is understand the emotions of children, and that we can do very well with play therapy. I think if we understand what they're going through, what are the real emotions, how do they feel about the entire situation, and then we're looking at a CBT possibly for adolescents, we might not even need a CBT for adolescents. If we really strike very young for these children, because if you look at research says the mean age of diagnosis is 6 to 21 years of age, which is already very high. And then by the time they actually probably come into psychologists, 12, 15, 18 and 20, when they don't feel like going back to the college, when they feel very demotivated, they feel that, why me? There is even a particular person who even said that, my mom wanted me to go off the ventilator, and I've heard her say, and she's told me about it later on, so I feel that, she's given up on me. So that's the kind of feelers that we get at adolescents and adults. So why do we wait for that kind of time? So I think if we can use eclectic approach of play therapy, we can use a lot of CBT in terms of understanding their negative thoughts, maybe looking at behavior modification in terms of replacing undesirable behaviors with desirable behaviors. I think we can make a mark in the lives and these families who go through a very traumatic phase, especially in the early phases of diagnosis.
Thank you. May I request Dr. Samit to come and share his experience of some survey he did about knowledge and understanding about Wilson disease among the parents.
Yeah. Thank you so much. So in short, what Sohini was trying to say is, you have a child with Wilson's, giving zinc penicillamine is giving zinc penicillamine. Taking care of a child with Wilson's is seeing that the child with Wilson does better in life overall, and it's not just about zinc penicillamine. So we were looking at a survey which we did with patients who have been under Children's Liver Foundations along with Indian Academy of Pediatrics and New Horizons. Just in the last month, this is like a pilot study, and the respondents were caregivers of individuals or the patients themselves, about 21 children we had looked at. Average age was 17 years, 3 months, but ranging from 7 years to 39 years. And it was a question-wise analysis and graphical data. So what we wanted to know is, leave the doctors alone. What are the symptoms that the parents or the society notes about children with Wilson's, and the earliest symptoms that you noticed in your child? And when we looked at this, jaundice, of course, was the earliest symptoms that parents or caregivers had noted. But also, if you see, incoordination, clumsiness, uncontrolled movement, stiffness, and behavioral concerns scored very highly. The point that we are trying to say is, we do not need to wait for the child to develop a full-blown acute liver failure and go to the hepatologist, or to have a proper neurological syndrome to go to the neurologist and thereafter then be referred for all these issues. So what were these symptoms? Mainly related to daily activities, academic concerns, play, which is the 4 responses that we see here, and no response. So if you see, again, most of these symptoms arise from the patient's daily activities. We looked at the ages at which symptoms were first noticed, the child was reported, diagnosed, received intervention. More or less, that's all in consonants. But you look at the time span that it takes, it's a wide gap. And who noticed or reported these symptoms? Of course, parents. But look at this, teachers and friends. How many times do you notice teachers telling you that your child has probably a pneumonia or a typhoid? So this is why we need to look at Wilson's or any chronic neurohepatological disorder a little differently. Even when we looked at the milestones, Surprisingly, I mean, we cannot assume the significance of this just from a small sample size, but there was even some delay noted in development of early milestones. So the overall conclusion is that let's not only look at it from a hepatology or from a plain pharmacology point of view, but it's a multidisciplinary presentation that we need to pick up, especially pediatricians who see the child earlier on. Concerns from school, concerns from behavior need to be looked at. You need to have a multidisciplinary evaluation. Of course, early intervention. So, thank you.
So one of the major concern is lifelong medication and compliance, and what is the importance, and second is the issue related with cost and therapy. So I request Dr. Mathai and Dr. Prashant to highlight this question.
The cost and that I'm discussing in the next
Yeah, so Prashant, you can talk about
Okay. The question is, many times when it comes to lifelong medications and compliance, people are very concerned in the initial part, and when things start to get better, that's when the, what you call it as, they start to lose the ground on it. They start feeling that, yes, patient is doing well, why should we give the treatment? And many times some neighbors, relatives, friends keep on telling that taking medications on a long-term basis, you will have a lot of side effects. And come Google, people will read about side effects. That is where the problems will start occurring for us. And this is the point where the treating physician's role becomes very important. Stressing the complaints every time they come, importance of telling the complaints. Because especially in Wilson disease, in our experience, it has been that people who were doing really good, extraordinarily good, miss the tablets, and then they start having the problems. And once you have this second time deterioration in your neurological symptoms, that leads to irreversible damage. That's what we need to understand here. So primary is the compliance is the most important thing. Initially, we used to think that it was more in the lower socioeconomic stratas or uneducated people may have this type of issues, but that's not the whole truth. Because it happens in educated people, well-educated people doing well. Because of late, I remember a patient who had neurohepatic form of Wilson disease, doing well, photographer by professional, skipped the medications, thinking that I'm doing well, there is no need to take the tablets, and then came back now having a significant hepatic form of Wilson disease going on. So it's very important to compliance has to be kept on hitting onto their head every time they come to us. That is the primary target, because this is where you make a difference to the patient.
I think one of the major problems is the side effects of penicillamine listed on the website, or you take the pamphlet that goes. Unfortunately, lots of side effects are reported everywhere. It may not be very common in practice, but the list is exhaustive. And any patient who reads through it, that's a big incentive to stop it. You know, it's very unfortunate, but in practice, I don't know how commonly we see side effects. Not that commonly as is made it out.
So that's what our role becomes very important, that compliance is met, compliance is met, compliance is met. Many times people ask us, can we come and show you once in a year, once in a 2 years? Fair enough, but many times these are the people who start missing out on the compliance because they are doing well. Make sure at least once in 3 to 6 months they come and visit you, make sure that prescriptions are going properly, they're not taking leniency on medications. That is what is very important.
Any disease which is genetic, lifelong, and has multiple presentations throughout life, it's a challenge to deal with this issue, and compliance is a problem. When we look at it as a specialist, I may look at prescription of a particular medicine as the only part of it. But it has to be understood that the family as a whole is a complex dynamic which needs to be engaged. And families get very confused, they do not understand, and very often we may think we have said everything, but they haven't understood half of it. So breaking it down to a level that the families can understand is a challenge. And this requires a great deal of documentation, because when multiple people are involved, there's a hepatologist, there's a pediatrician, there's a neurologist, there's a developmentalist, multiple people involved, it becomes very confusing for families. And that is one reason why compliance is poor. So right at the beginning, sitting down, organizing a program, explaining bits and parts of all of it on the program, and that kind of counseling is really going to help compliance.
Dr. Matthew, can you address us about pediatrician has diagnosed a hepatic form?
I think what you mean by saying is, should you involve the other specialists also?
Yes.
I would think that it should depend on whether the patient has a symptom. The patient has a behavioral problem, get a counselor. If there's a neurological symptom, get a neurologist inside. But otherwise, I think a thorough clinical examination and a good history, I think should suffice. We don't need to be sending them round and round on to multiple visits. I'm really not sure that's necessary. Unless you're not sure about your neurology or you're not sure about your ability, I think you should just stick to yourself. And
If you have stuck to your basics.
I think you don't need anybody else.
So, just last slide. So, we have a high diagnostic errors and delays. There are implications. Sibling screening and parent screening, there are gaps elsewhere in our country also. Compliance with special reference to gender. In our country, obviously, I have seen like male child, the parents will give medicine, female child, they will not give. Lifelong treatment and financial issues, lack of support from pharmaceutical sectors. If it is epilepsy, movement disorder, stroke, all pharmaceutical houses will come. The involvement of NGO is important. We need to decide about impairment, disability, quality of life. And lack of facility at tertiary care. Tertiary care means I talk about state medical colleges. And mutations are too many, gaps are there also. And we should take a pledge that we should not decide a autopsied brain of Wilson disease again, because it's eminently treatable condition. We should not see a brain. It's unfortunate that we continue to see. Yeah, we can have questions.
I think regarding the counseling and the compliance, it's a big issue everybody is facing. What I do in my practice is that I explain to the parents, child, if you understands, we have to make the child sit, and then tell them, look here, this medicine is your life committed thing, and you can forget your diet, but you cannot forget this medicine. This is one way we have to convey them, look here. And then second thing is, which is very important, is that one of the parents has to administer the medicine. Mind it, if you leave the medicine to the child only, that he will take or she will take, they will never take. Take it granted. चाहे तो वो तकिए के नीचे पड़ी होगी, मंजे के नीचे पड़ी होगी, जब बाहर पड़ी होगी डस्टबिन में. This is what is happening actually. I think we have to face the reality and come out with something that how we can ensure this. This is very, very important. Then the adolescents, this period when they are moving with their peers and they are away from the home, they are going for professional degrees outside, this is again a big issue. I have 2-3 patients who deteriorated, in fact, and I had to made sure that one of the parents should stay with this very person to ensure the medicine, because the fellow came in a very bad shape. Though could survive, otherwise he was fit for liver transplant. So he could make it. I think we have to ensure at that level also, because that is the age when they don't understand. They are always in full swings. They will not eat anything. They will not take medicines. They will throw it off actually. So that is becoming a big problem actually. So professional students, those who are going outside the home, they are not following actually. That's another big problem I think we have to address too, because how to tackle this type of issues and so on and so forth. Whether
Thank you so much,
yeah,
sir. If there are any issues, all panelists are available. They are available for discussion also. Thank you.
It's a very important area actually. पहले तो for this audiovisual team elections over हो गए, महाराष्ट्र में भी हो गया और यूपी में भी हो गया, बार-बार ये वोट डालने की प्रक्रिया बंद कर दो. ऑलरेडी हो चुका है, पंजाब में भी हो गया, बंद कर दो ये. Counseling, as far as you have been, is a very important session actually. The crux of Wilson's disease is based on this thing. How to diagnose, and secondly how to treat and how to counsel. That is the most important aspect of it. What Dr. Thapa has said, we must spend some time with the patient and tell them, emphasize on this medicine that it is as important as your food. I tell them breakfast. सब कुछ छोड़ देना, लेकिन ये दवाई नहीं छोड़ना. Second point which we have to tell them that if you leave this medication, your liver disease will worsen further and you'll be in a big liver failure problem. So to bring you out from that is extremely difficult. So these are some of the key things which we have to tell these people. Regarding Google, what John said, that the best thing is how to, actually it may be wrong. अरे Google जो है ना, Google पर जो देखा है आपने, ये अंग्रेजों ने लिखा है, हमने नहीं लिखा है. भारत की स्थिति डिफरेंट है और वहाँ की स्थिति अलग है, उसको मत देखो. These things do happen with every disease, and therefore the best way to cut it down is to deviate them from that pathway of Google. Everybody these days comes with the Google search. So we have Wilson's disease, one patient in our from a Times group actually admitted, and every day there are so many questions because they read from Google and they are doing the cross actually consultation. So these are very important things. Timely follow up what he said is important. 3 months. First we should do quickly, first 3-4 months, and then we should call them every 6 months for this. So that is very, very vital. And we are also enlightened by the neurologists today that what should we do once they develop a neurological problem while they are on depenicillamine therapy or on any kind of therapy. So we have to, that is a very big question in our mind. When we send to the neurologist, they stop depenicillamine. I don't know the reason. They give zinc. No, I'm just telling you. Some of them have this notion that it
Sir,
is
at
depenicillamine.
Nimans we have the largest series of Wilson's disease.
Right. So
Majority
we don't.
all patients
When
are
they
on
come
both
back
zinc
to
and
us after
penicillamine.
consultation, we say no, you have not to stop, you continue with this medication. So these are important.
Unless there is a reason for stopping, we don't stop, sir. We have the largest series of Wilson's disease on the earth. We give both zinc and penicillamine.